We are, we all need to know about this because it's become an important point with the feds and with the provincial government to consider when we're talking about safer supply for people who need it. So from coast to coast, we acknowledge the stolen and traditional ancestral ceded and unceded territories of First Nations people, the Inuit and the Métis, the people that call these lands home. We reaffirm our commitment and responsibility to care for the lands, to work and strengthen our relationships with First Peoples, and to improve our own understandings of their unique history, homelands, languages, cultural practices, and spiritual beliefs. We acknowledge the harms and mistakes of the past and the present. Let us consider how we can each in our own way move forward in a respectful and meaningful spirit of reconciliation and understanding. Let us bow in acknowledgement of to the thousands of children who died at the hands of colonial powers and to the families whose hearts are broken to this day. So let's think about that a little bit. You can put your own land acknowledgement in the chat, and I'll hand it at this point over to Jeremy, who is the co-founder of the Drug User Liberation Front, centered in Vancouver, a group of incredibly brave and courageous people who just took matters into their own hands to move forward in a better and stronger way, the idea of safer supply. So Jeremy, take it away. Thank you.
Awesome. Thanks for having me. And I'll acknowledge that I'm giving this presentation from the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh nations, as well as all the Coast Salish peoples. And as we kind of progress down this route and advocating for safe supply, we keep in mind that it's Indigenous populations who are disproportionately affected by the harms of the illicit and toxic drug supply, and that anything we do needs to be kind of grounded in different ways of knowing, particularly from the populations who are being truly affected by this in the most horrendous ways. So I'm going to go ahead and hopefully this shares correctly. Okay, fingers crossed that you can see the presentation right.
Yeah.
So this is a presentation on community-led compassion clubs and what we believe is the next logical step in harm reduction. And I think really at its heart, that's kind of what safe supply is a way to reduce the harms of substances when they're used. And while we may be kind of framing this in the kind of context of cocaine, heroin, methamphetamine, and kind of generally all the opiates, as well as that every person who uses drugs should have a safe supply of drugs, just like many of us do have with cannabis and alcohol and the foods we eat. So who is the Drug User Liberation Front? We're a collective of groups. We are led by people who use drugs and the organizations that represent them. We have membership from the medical community. We have doctors, nurses, we have academics, we have lawyers, we have some of the top addiction substance use researchers in Canada who are part of our kind of liberation movement. And really what we want is to see change that isn't happening in the systems that exist. And we realized that there was a real need for a group like DULF who's willing to take radical action and doesn't have isn't tied down by the kind of limitations put on them by funding, or we don't have things dangling over our head that will make us less likely to act. And that's what was really needed. No kind of holds bar on a group that really needs to push for something that's very much needed. And so framing the situation, as DULF was beginning to form right at the beginning of the pandemic, so it was kind of around April 2020, maybe a bit before that, The overdose numbers in British Columbia were again beginning to spike to unseen levels. And for context, when the overdose crisis was declared, and it's not so much an overdose crisis, it'd probably be more accurately described as a drug poisoning crisis or a crisis of drug toxicity or drug policy. But when the overdose crisis was declared, there were around maybe 300 deaths per year. And now now that the record-breaking year was 1,500. So that's a multiplying by 5 times, and we're on track to break another record, having the most overdoses ever in a year, and that's kind of where we're heading now. And things only seem to be getting worse because all the responses that have been conducted have been wildly insufficient and flawed in ways that the community was saying since the beginning that this won't work, because we're in the systems that you're trying to utilize to fix the problem, and it's like we can already see how it's going to progress. So it's really bringing the kind of community-driven, community knowledge, different ways of knowing into the kind of policy landscape and trying to really push things forward like has been done in the past through kind of drug user activism, which I'll get to later. So the DULF position on safe supply is that a safe supply are substances of no potency and content that provide a way for people who use drugs to use drugs in an accessible way that accurately conveys the risks of the substance. And the kind of key point there is it needs to be accessible, because British Columbia did try to provide a quote safe supply of Dilaudid and Dexedrine and a few other things, but the problem is that it's not accessible and it's not what people want. So those are kind of 2 reasons why it wasn't going to work. And being in the medical system is an inaccessible way to access substances, because you can imagine going to your doctor and you want to have a party on the weekend, or you want to enjoy a 6-pack, and you ask your doctor, oh, can you prescribe me a 6-pack? Your doctor's going to say no, like that's not healthy for you. But that kind of removes substances from their kind of it's not contextualized in the way that substance use is actually undertaken, and it's not necessarily something that's always best for your physical health, but there are other implications there as well too. Like some people want to use substances for fun. I think probably a lot of us in this room would probably use substances that are illicit and for non-medical reasons or recreational reasons, and that's not that doesn't work in the medicalized system. Further, for people who have really high tolerances or are in more chaotic patterns of use, the medicalized system doesn't work well with that either, and tries to put the constraints on them that people who use drugs or people who are accessing these services that they can't necessarily meet. So in this kind of medicalized model in BC, prescribers don't want to be the gatekeepers to substances, and that's what I've heard overwhelmingly from doctors who are prescribing, is that they don't want to do that. And the ones who do are bullied by their colleagues into not prescribing because of anecdotal cases of harm, and we can't base our kind of policy decisions off of these kind of anecdotes of whomever. And while we advocate for a kind of community-based way of knowing model, it is based in academic evidence as well. We have a application that we did up for an exemption application, and it lays out the evidence in a very clear way and really makes the compelling argument for this sort of model. And finally, medicalization of any service will reduce the uptake and effectiveness. And there's a citation there for a study that was done on, I think, overdose prevention sites, where they looked at medicalized models and non-medicalized models. And it was easy to see that when you begin to medicalize things, the uptake goes down, and people don't access these needed services. But what's driving the harms and overdose in British Columbia and across Canada? It's the kind of overarching policies of prohibition and enforcement. So we know that when you prohibit something and make it illegal, it pushes it into hiding, not only the drugs, but also people who use drugs. So when people are trying, if you have a prohibited, when drugs are illegal, people need to smuggle them across the border and are competing with seizures and these kind of enforcement of import. And there is an incentive there that's very logical, that when you're kind of competing with this sort of patrol and seizures, you need to make sure that when you get something across the border, it's a real payload. So economically, it makes sense to get the most potent drugs to be able to get across the border. Or if you're I think there is some cases of synthesis in Canada. You want to make the most potent substances to be able to get the most money out of the kind of precursors that you're using, right? It's kind of a value sort of situation. And there's some very interesting videos and studies that talk about enforcement, in that when you have an enforcement sort of like initiative against things, that when you bust a dealer or when you bust an organization, it opens up a niche in the kind of environment that will be filled. And when it is filled, it's filled with more cunning, more violent organizations that can hold the space in a better way. And it continues to push it towards the more violent systems. And there's a really good video online by Neil Woods that talks about the same case in the UK, and why he, as a kind of undercover officer trying to dismantle these rings, stepped away from that system. And really getting to the kind of the core of the issue is that when we have a supply like we do, and that supply is unregulated and highly variable, people don't know what they're taking or how potent it is. And we have some slides coming up that kind of demonstrate that. But if you're a person who's going to be using opiates, you don't know if what you're getting has carfentanil, which is 40 times stronger than fentanyl, or if you're taking fentanyl that's at like a 5% potency or a 50% potency, and you don't know. And that's the difference between having an enjoyable time in medicating, or dying, overdosing and dying. So this is a figure of the overdoses in BC. It's not updated to the most recent months, but we can see that we're trending for a new kind of record, and that the overdoses have significantly spiked since the declaration in 2016 to now. And one thing that's very interesting is laying on top, and this is data from the BCCSU in a report that they did, is that the fentanyl concentration, that's that kind of dark blue line there, and the bars on the bottom are overdose deaths. And you can see that as the kind of median fentanyl concentration goes up and down, as do overdoses. And this is kind of the real interesting data. And this is unpublished data from the BCCSU that they kindly lent to us. And this is from their drug checking services. This red dotted line going down is when the declaration of the COVID-19 health crisis was declared. Borders were shut, and you can see the light blue line on the bottom. That's the variance of fentanyl concentration. So the kind of spread between the lowest concentrations and the highest concentrations, and a few mathematical functions applied to it. But you can see that as soon as the COVID declaration was declared, that the variant shot up. And that's really kind of what we're getting to, is that there is really no way of knowing how potent your drugs are, and that's exactly what kills people. We think that there is a solution here, or at least an interim solution, or something needs to be done, an impetus to act, and that's providing people with a way to get a consistent supply of drugs. And we believe that's through a compassion club, a demedicalized compassion club, because it needs to be accessible. And there's different ways to kind of conceptualize compassion clubs, but the way we prefer is that it's kind of conceptualized as a market intervention, something similar to like a kind of drug administration, where you can control the quality of drugs through either introducing them yourself or creating kind of this expectation or model for accountability. And what we'd like to do is, if the main thing that we'd like to do is get clean drugs and get them to people who use drugs, and we prefer that through a pharmaceutical route. But with the tools we have at our disposal and the necessity to act as people are dying in droves, so we have to act within the illicit market until we get sanctioning, if we can ever get sanctioning. So what we'd want to do is integrate into the existing lines of substance distribution. So that essentially means buying drugs off of dark markets, whether that be in person or online. We prefer to do it online to kind of increase the safety and reliability of getting substances, and I'll get more into that later. But also increase the power of consumers, and that's a really, really powerful thing, is when you get people together and able to act as a collective group against these very powerful forces. You're able to leverage economies of scale. You're able to like really say what you want, how you want it, and have the funds to put behind that. And in an unregulated market, that's a big driver too. It's the money. So there's also that kind of plays into it. When we get these drugs from the community, or whether that's online or in person, we test them with available drug checking technologies. We package them into boxes, or if we have funds, we can get kind of tamper-proof packaging, and then make sure we have accurate labels of how potent the drugs are and what's in them. Then once we did that, we would be able to redistribute to Compassion Club members in a safe and accountable environment, removing the kind of aspects of violence from the existing system. Why we can't wait? The overdose deaths are continuing to increase at a very alarming rate, as I just previously demonstrated. Even though there have been cries for years and years for a safe supply and some tangible action, there's been none, and that kind of demonstrates that politicians and the kind of public at large are generally apathetic to the ongoing crisis, and that if the community or caring citizens don't step in, nobody else is going to, and we're going to be 5-10 more years into this crisis watching the same trends. And also, as a ex-drug checker with the BCCSU, I was able to really watch kind of developing trends. There's also evidence coming out on this as well, is that we're seeing those kind of forces of prohibition continue to manifest themselves by introducing more addictive and stronger substances into the drug supply. So we're seeing benzodiazepine contamination into the supply of opiates, and recently we saw benzodiazepines in cocaine. We're seeing novel analogs of fentanyl, and people trying to produce carfentanil. And actually right now in Vancouver, we're seeing another wave of carfentanil go through. And whenever carfentanil comes into the market, and if it's introduced into the market consistently, the deaths are going to skyrocket again. But right now it comes in waves, and one's coming through right now. And if you live in Vancouver, I'm sure over the last month you probably had people that die, and I would attribute it partially if not significantly, to the carfentanil going through.
Jeremy, there's a couple of questions
Sure.
just related to what you're talking about now. So Carrie Waters had the question, are you paper spray testing or mass spec testing?
So the substances from DULF, we have been testing them with FTIR, and then recently mass spec became available. So we're also sending them to Victoria to get mass spec tested as well. There's flaws in all the technology. If I were to choose a technology that would work best, you know, just from a effectiveness point of view, it would be nuclear magnetic resonance. NMR seems to be the best way to really determine what's in people's substances, but they're very expensive, very big, and they're, you know, essentially giant magnets that couldn't really be, you know, used in community, at least not any way that I know. Oh yes, to answer your question, we do FTIR and paper spray mass spec. And we also send, sometimes through BCCSU, we can send samples to Health Canada where they test them with NMR as well.
Great. And I have another question from from two people attending. Who is going to purchase the drugs that the compassion clubs will distribute? And yeah, we'll start with that one first.
Sure. So it depends on if we get sanctioning or not. Well, I guess it doesn't really depend. It would always be DULF through the membership. So there seems to be some sort of kind of misconstruing of the model in the media, saying that, you know, we're trying to get free drugs to everyone. It's not true. We think that, you know, in this model that people should be able to, you know, pay for some of their substances. Not to say that there shouldn't be free drugs. I think there should. But what we're really pushing for is just regulation in the supply so people can, you know, purchase their own drugs at cost. So we would pool money from the Compassion Club members to purchase the drugs, make sure that they're safe, and then redistribute at cost. So leveraging those economies of scale to bring the price down.
Great. Thank you. And then another question, how do you become a Compassion Club member?
Right. So we aren't currently running any compassion clubs, but the model is going to be one that you access it through, you know, drug user groups. That's probably how we've been giving out drugs so far. Is if you're a member of a drug user group, we connect with the drug user groups to suggest people who would, you know, benefit from receiving a safe supply dose, and that kind of helps to kind of select and screen out people who aren't drug users who may be trying to, you know, get the supply, which is really not what you know, anyone wants it at this time.
Yeah. Okay. And just a comment that from Corinne in Victoria, 70% of the drugs tested here contain benzos. This started about 6 months ago. Is that something you're seeing you're in Vancouver?
Right? Yes. It's benzo effects. I mean, etizolam, I think, is the drug that's going around mostly, and it's not technically a benzo, but, you know, effectively it's a benzo. And yeah, it's you know, probably about half the drugs we test have them, and the current testing technologies, at least, you know, FTIR and the test strips can't reliably pick it up. So it's, you know, really hard to tell, but I would say yes.
Okay. And Samantha asks, just regarding compassion clubs, how would you decide if it's a drug using group?
They're groups of drug users. So there's some that have been established for a long time, like the Vancouver Area Network of Drug Users. And to be a part of them, you have to go to the drug user group, sign up to become a member. To be a member, you have to self-identify as somebody who uses drugs. And again, we aren't the medicalized system, but you also have to go to meetings there and kind of become more ingrained in the community. So, you know, if there's a drug user group that you know, is established and that we know and we trust, then that would kind of be a drug user group. I mean, yeah, that's kind of it. They're already kind of established. I mean,
Great.
there's also other ways that people could access as the model becomes scaled, and that's like a kind of membership application where you're screened by a member of the community and a member of the Compassion Club, and just a quick interview to see if you're a good fit or not.
Okay. How are you doing, Jeremy? There's a few more questions. Are you fine to answer them, or do you want to carry on with your slideshow?
Yeah, might as well. Let's do it.
Great. Okay. Christine asks, is this only a BC-based program, or are there other ones in Edmonton that you know of? She mentions.
Again, we've only done 3 actions, and they were very political, highly publicized demonstrations. So we don't have a Compassion Club going. What we're applying for is to have a Compassion Club in BC that could hopefully expand. And I know there are other groups who are planning to push for safe supply in other places as well, but it probably wouldn't be the Drug User Liberation Front, but who knows?
Great. And Alex asks, when planning for this, how do you navigate law enforcement? Are they a partner or a barrier?
I think they could be both. Previously at the demonstrations, we've always emailed the police, told them what we're doing, when we're doing it, at what time, and they've always provided traffic control. They've never enforced against us, and they've responded to some complaints made against them for not enforcing against DULF, and kind of reiterated that to enforce against us may not be in the public interest. But they won't work with us yet, even though we've sent them invitations and continue to send them invitations to give us their input, let us know what they think, because we want to find a model that works for everybody. So they could be a partner. They aren't really being a barrier, and I guess that's the best we can hope for in the current system.
Great. Question from Maricia. If I don't have your name right there, so my apologies. How many members will there be initially?
So we sent 2 different applications. We sent an application just for an exemption, and with the exemption only, then it would kind of be as much as we could administratively handle, and we'd have to look at how we could scale up and still kind of maintain a good system of administration. But we also submitted a SUOP, the same one, same funding that Moms Stop the Harm got some of their funding from, and that's substance use and addictions programming. And we asked for money to do a 200-person pilot. Great,
awesome. Rochelle asks, if unsanctioned, how would you deal with robbery, keeping people safe, law enforcement, etc.?
I mean, it's just like the in terms of law enforcement, it'd be the same as operating an unsanctioned overdose prevention site. I mean, there's really no protection there, and it's an unfortunate reality of drugs being illegal, or even in a decriminalized system. It'd still be tough, but under a decriminalized system, I think it'd just be more the distributors or the Compassion Club itself that's more at risk, as people are allowed to carry out different doses. Keeping drugs safe and robbery, I mean, that we do our best with safes and locked doors, and that's all we could really do. I mean, we'd probably try to get maybe partner with Mark Tyndall and MySafe and potentially be able to distribute out of some sort of system like that. But again, we'll have to figure it out as we go, but we're planning to have stuff locked up.
Great. And Carrie asks, are there legal supports on board? I'm not quite sure what she means by that, but.
Sure, I mean, I can give it a crack. I think we do have lawyers to support us, and whenever we do actions, we make sure that we retain a criminal lawyer just in case. So we have some protections there, and if the Compassion Club were to be resourced, I'm sure we could have some sort of lawyer on retainer as well to help protect the Compassion Club and the participants.
Great, and we'll just take this last question and then have you, I know you have more to share. So from Claire, are there any gaps in research literature that would help promote legal and social change regarding this kind of thing?
Yeah, I think, there, which is what we're pushing for, is a study on a demedicalized supply of drugs and how that can help people. I think that's a big gap, because we're pushing for something that hasn't been done, and people are asking for evidence on it. But it's like a catch-22. We can't study it unless we have evidence, but we can't get evidence unless we study it. So that's what we're pushing for. There's a big gap there. There's evidence for heroin-assisted treatment in medicalized context, but for demedicalized context, it's sparse.
Great. Thank you, Jeremy. We'll let you carry on.
And so now I'm going to get into some of the logistics of compassion law, some of the theoretical sort of logistics. And there's 6 kind of big benefits that come from a compassion club if it were allowed to access a pharmaceutical supply, and 5 if it weren't. So the first is that it acts as a quality control checkpoint. So drugs can come through a compassion club. They can test them with the technologies that are available to them, and they can make sure that what people are getting are a consistent supply and that they know exactly what's in it. And we can have clear and accurate labeling that's not currently available with the drug supply, so people will be able to see what and how much is in their substances. It can also act as a community connection and innovation space. So as you have people who use drugs coming together, there's no reason that these spaces can't act as sort of community hubs as well, and be offered in tandem with other services like overdose prevention sites and meetings and community growth and social capital building. It acts to kind of centralize and increase the purchasing power of consumers. And it can also act as a portal to other services. So if people need to access medical or social services, right now they go to their person who sells drugs, or the kind of unaccountable dealer. But if they came to a space like a compassion club, there'd be a place where if you wanted to reach other services, that there'd be people there to help you. So it's really kind of increases those connections to other services. And this last one's only applicable if we are able to get it from a pharmaceutical regulated supplier. But if we were, or we were to produce it ourselves, but I don't think we have the know-how to do that. But anyways, if we weren't getting it from the black market, it would significantly put a dent in kind of the funding that the black market's getting from this trade, and weaken that system, which I think is overall positive for society. So again, these are the logistics, and it's 5 points. So there's a membership assessment, market navigation, quality control, packaging, labeling, and distribution. So when people, if we screen potential members who seem like they'd be good, then we could do a quick membership assessment with them. And it'd be like super low barrier, and we just want to make sure that we're people aren't identifying as youth, or people who don't use drugs aren't getting the supply. So we do it in person by someone who uses drugs and somebody who's a member, a staff of the Compassion Club. And if they're accepted, they can fill out the application form, and we would recruit through existing and established drug user groups, like the Vancouver Area Network of Drug Users or Solid. And there's about 12 groups in BC that are established groups. So navigating the market, we in the kind of unsanctioned logistics, we really have 2 options, and that's whether buying drugs in person or buying them online. And of course, we would prefer to get them from a regulated and legal supplier, and that's kind of at the top. If we can do that, then we're really making something work. But in the meantime, or if we don't get sanctioning, then we have to choose between 2 really undesirable options. But one is more desirable than the other. So if we're buying in person, there's the risk of robbery or violence, especially when you're dealing with large sums of money. and large sums of substances. However, there's another option where you can buy online through the dark web, and this presents a lot of really interesting benefits. So if we were able to, if we're buying off the dark web, the nice thing is you go onto these markets that are kind of like eBay or Amazon, where there's like a ton of substances and a ton of like things listed on these websites, and you can leave reviews on how the substances work. So that acts as kind of an accountability mechanism too. If something's highly reviewed by a lot of people, you can have more confidence that it's going to be what it's actually listed as. And when you buy something, you place your money into a thing called escrow. So it's a third party who holds the money. So you pick the drugs you want to buy, you give your money to the third party. The seller sends you the substances, you take them, test them. If they're what you want, you tell the third party, I got my stuff and it's what I wanted, and they release the money. But if it's not, you can create a dispute, and the third party determines whether or not your dispute's legitimate. And if it is, then you get your funds back. And there have been several cases where we've been able to do that. When we've tried to order heroin, got fentanyl, we said this isn't what we wanted, and the third party has sent us our money back. So that's a really significant benefit, and introduces a really powerful accountability measure as well. So once we got the substances, we'd be able to do quality control on them. Again, we're going to try to do FTIR and recently available mass spectrometry testing to ensure the quality of the drugs. And a really cool sort of aspect here is that if you are able to drug check for people who are distributing drugs rather than the kind of bottom level, just the general population who's using them, you exponentially increase the effectiveness of drug checking by bringing it up a level and if you're drug checking for a club that's giving it up to 200 people, you're essentially drug checking for 200 people in one drug test. Some of the design inspirations, and this was done by the other co-founder of DULF, Eris Nix. She wanted the design to be very, very plain. We wanted it to be similar to packaging that's done for like vaping, or very, very plain packaging, so as to not be like a draw in. So we tried to keep it as plain as possible, and inspirations coming from things like Juul, No Name, wall art. Here's some of the packaging. These were the kind of first generation packaging, and these were small boxes that contained about a point and could even contain up to a gram. And as you can see, we have a warning label that kind of warns of some of the harms of the substances. We have clearly labeled what the substance is and what's in it, as well as warnings of to not operate your car, or that these drugs can cause dependence, overdose, and addiction.
Jeremy, there's a few more questions.
Sure.
Yeah. So Carrie is asking, what is a third-party example?
It's the website that is acting. It'd be like kind of eBay. So you know how the seller is not eBay. So we'd essentially give our money to the website, and then the website would hold it until we got our drugs, and then said either thumbs up or thumbs down. So it'd be the website. Okay.
And from Karen, what do you anticipate in terms of numbers of users that may have access to the Compassion Club, or does it rely on the number of Compassion Clubs developed?
Yeah, I think it's kind of each is dependent on each other. I think they're correlated. I mean, ideally, we'd be able to serve every person who uses drugs who can't access other services that are better for them. So I mean, I don't know if I could really answer that, but we're applying for a SUOP to do a 200-person pilot, and if it were to expand it, I'm a proponent for expanding it as much as possible. I mean, I'd love to have a Compassion Club everywhere there's like a liquor store or something. People need to be able to access it. So
great. And from Nicola, how would you assess whether drug dealers were infiltrating Compassion Club membership and have access to money raised?
Well, I mean, DULF would be a drug dealer essentially, but if I think you're saying like, what if drug dealers are getting the drugs and diverting them, and I don't think it's necessarily a bad thing. I mean, I'd want the system to be more of, you know, one where people would rather buy off of DULF than a drug dealer, and that's really what we're going at, because drug dealers would be purchasing it at the same price that DULF would be selling it. So I don't know why somebody would want to buy off of unregulated if they had a regulated option. And that's what really the model is trying to shift those forces, because people will always be able to buy off the dark market. And finally, if people were, you know, if a drug dealer was buying safe supply and then selling safe supply on the market to other people who use drugs, I think that would be a fine thing. But they'd also be buying much more than we'd be giving an individual. So it kind of raised some questions, and I think we'd be able to sort of solve pretty fast. Someone's buying, you know, 4 grams a day, or you know, to somebody who's trying to buy, you know, ounces every week. You kind of.
Great, thank you. And just, there's been a little bit of a chat on how people can support your application. And just to note that Heather Hobbs, who's here with us today from the Safer Supplies, just noted some website information on how we can support DULF, and that's in the chat. So lots of support behind your application to SUAP. So we look forward to hearing back from that.
Cool.
Thank
Yeah,
you.
I'm very excited as well. All right, here's the second generation boxes, and these were kind of bigger, and they were meant to be a little bit kind of comically big, because again, we were doing demonstrations. So these boxes contained 3.5 grams, but they were like super big, and it was for show. I mean, in you know, effect, we'd probably use the kind of smaller boxes or smaller sort of packaging when we were actually operating at scale. But again, this kind of demonstrates another way that things could be packaged very plainly, with, you know, very clear warnings and clearly labeling like what is in the substances and how much. So distribution, the substances would be distributed at cost to club membership. So again, no, we're not planning on giving out drugs for free at scale. In our demonstrations, we give them out for free, mainly because it'd be very I don't think it'd be perceived very well if we were selling drugs as opposed to giving out drugs. And that was a very kind of, you know, deliberate decision to give them out for free to make sure that the demonstration was perceived better. And I think we would have probably been arrested if we were selling them. And the substances were obtained through private donations. So, you know, we gave them out for free because we didn't pay for them, and we wouldn't want to make any money off of people. And due to the dependence on illicit markets, the kind of future prices will reflect how much we're paying for the substances, or if we're buying them off a pharmaceutical supplier, it depends on how much they're selling them to us for. But again, as we, you know, pull people's money together and have more purchasing power, we can leverage better prices and pass those savings on to club members.
Jeremy, oh, sorry.
Yep.
Another, just a question. Drug users need their dope at all times, day and night. Will the club reflect this with your operating times? Is that something you've thought about? I'm sure.
It absolutely is. And we also acknowledge that and would absolutely try to be open, you know, as much as possible. And I really think there's potential there for collaboration with things like MySafe, where you can have, you know, a vending machine that's, you know, kind of linked to bioidentifiers and are very secure, that people could access 24/7 with, you know, anyone kind of sitting there and making sure that things are just going all right and that nobody's kind of trying to crack into the machine. So just some kind of, you know, low-level staffing, you may be able to really stay open for very flexible hours. Cool. So this is a flow chart or a logic model that I created. This one was created for heroin compassion clubs. And I did it as a school assignment. I just thought it was kind of interesting to plop into this presentation. But essentially, you know, there's a very kind of logical movement through to get from what we want to do to what we think the results are. And of course, this would have to be evaluated, but it really kind of points out what we think will be the outcomes of, you know, a compassion club. And you know, kind of looking at the last two columns there, outcomes and impacts. You know, the outcomes that we want a more consistent supply of opiates. We want reduced financial strain on club participants. We want reduced reliance on street supply, increased access to services. You would want to create a standardized model if you're doing a pilot so that other people or other organizations could also take on this endeavor. And we also want to increase the evidence base and knowledge for compassion clubs and address those gaps in the literature. And the impacts, reduced overdose, reduced crime, reduced power and resources of organized crime, healthier participants, improve public perception of harm reduction, and expansion of compassion clubs. That's really that's what we want to do. So DULF is in a very unique situation to intervene. And in partnership with the community groups that we work with like DULF, like Vandu, WARS, Coalition of Peers, all the drug user groups across BC, all the academic institutions that are part of DULF. Because we have deep and meaningful connections with the provincial network of people who use drugs and local drug user organizations, which a lot of other organizations don't. We have the technological skills to be able to source substances from the dark web that a lot of people in the community aren't able to do. We're also willing to work with a diverse group of stakeholders to keep people who use drugs alive and healthy. So we're willing to work with groups whom we might not traditionally work with if it keeps people safe and alive, because that's our ultimate goal. Keep people safe and alive, and we don't care who we have to work with to make that happen. We've also demonstrated that we have no desire to profit off this model, and that we really just want to help. So far, we've done a few things. Overall, we're conducting a necessary act of humanity, operating episodic cocaine, heroin, and meth compassion clubs across BC in demonstrations to increase the discussion and knowledge of compassion clubs as a potential solution. We demonstrated that compassion clubs can be run by community, and if allowed to operate, will save lives from overdose and other substance-related harms. And we've every time we've done an action, we've released demands, and we've demanded that the appropriate levels of government innovate to either provide sanctioning for this program to continue to operate in community, or take real action and implement the compassion clubs themselves. So we've submitted an exemption request, a Section 56 exemption request to the Controlled Drugs and Substances Act. We've also submitted a SUOP application for funding to run a pilot study. These were both submitted to Health Canada. And in these applications, we've received support letters from some very impressive institutions and partners, including Vancouver Coastal Health, the City of Vancouver, Fair Price Pharma, who offered to produce the heroin for us if we got sanctioning. We had a letter of support from the BC Center on Substance Use, Moms Stop the Harm, Portland Hotel Society, Law Enforcement Against Prohibition, Vancouver Area Network of Drug Users, First Nations Health Authority, and many more. And they're all available at our website. If you go to dulf.ca, you can take a read through those letters of support. And this is important. I think we really wish that we didn't have to do this. It's not really something that's enjoyable for us. We aren't criminals. We don't want to profit off of the illicit drug market. We're just very concerned citizens, people who use drugs, academic professionals, and organizations. It's a very intimidating thing to take on sometimes, especially with the risk of jail and incarceration. And every lawyer that we talk to is like, you very well could go to jail, and that's a very scary aspect. But it's something, it's like an impetus to act, and it's just so logical, and it makes so much sense. We can't ignore it anymore, and we know through history that no meaningful progress in drug policy happens without the community, and really historically in harm reduction, drug user groups taking action and doing things, and then it being adopted into the system later. And we've seen that happen with overdose prevention sites, supervised injection sites, needle exchange, and a slew of other things. It's that it does not happen without community taking action first. And we believe this is the same way that compassion clubs are going to progress, is the same way that these other initiatives progressed as well. So our kind of motto is from rhetoric to resistance, or from rhetoric to reality. So we want to move safe supply from something that's talked about to something that's actually done. And here's one of our actions in front of the Minister of Health of BC's office, Adrian Dix, where we gave members of wards some of the safe supply. And then we also have Jean Swanson here giving out substances at another one of our events in front of the Vancouver Police Department. At the in front of the Minister of Health's office, it was actually Mom Stop the Harm who gave the drugs to wards. So cheers. That's the presentation.
Thank you so much, Jeremy. We still have a number of questions on our chat if you've got time.
Oh yeah.
Let's chat further. And that was an awesome presentation. So we have a question from Aaron. He asks, will there be space for including black market dealers in this new dispensing model?
I think it depends. I think we obviously want to integrate community as much as possible. Maybe some of the roles may be a little untraditional. And of course, this is gonna be a growing kind of evergreen project where things are changing as we go. But I think a good way to answer that is, if we don't get sanctioning, we're going to need to buy substances somewhere. And if there is, people who are selling drugs, or black market dealers who can get a consistent supply of drugs, there's no reason we won't get them off of them.
Great. If people are accessing pure substances, perhaps for the first time, what are the associated safety risks and how are those being mitigated?
Again, what we're trying to do is, have it for people who already use drugs, potentially at scale, if the black market was, removed, and there were, if this was the only place that people could go, and this is, people really wanted to use drugs, I think there could be some sort of, process to bring people in. It's like it'd be similar to when people are trying to use overdose prevention sites for the first time, and they do the same things there. Is they have a meeting with somebody, they say, what's going on? Are you sure this is something you want to do? Maybe there's potential other avenues you can try first. But if you're really going to use drugs and you really want to, then they're here for you.
Okay. And from Naomi, how would a compassionate club work in a rural setting?
Again, I think there's real potential for these, MySafe machines, or all dependent on funding. Like if we had enough money, we could run them wherever. But if we were kind of limited, there's potential for these machines to be set up, in every community. I mean, they're very secure, and they require very little, resources to operate. So I think that's a real tool that could be used to expand to rural places. But I think operating unsanctioned, there's also mail. Like that's how we get our drugs, is they get mailed to us. So there's no reason. I'm not saying we're gonna mail drugs, but we could.
Okay, good. Thanks, Jeremy. From Maria, would there be a limit on how much a person can purchase at a time? If so, how would that limit be gauged and why?
I think we'd probably do it on an individual basis and make sure there's lots of room for people who want to use enough, or really want to have a party, especially with things like cocaine. people can use a lot. So no, we don't plan to have limits. But if there's a real outlier of people who are buying a lot, it may be, there would be some sort of like agreement that people would sign that they aren't going to be selling the drugs. And if there's kind of red flags that are going off with really kind of unusual amounts that are being purchased, then it rates some flags. But other than that, I don't think we plan to have limits. But again, we want to work with different stakeholders to find something that works for everybody. So this is just the perspective from DULF and his partners, but we're willing to compromise if it saves lives.
Great. And from David, would compassion clubs provide safety monitoring during drug use, the way overdose prevention sites and safe injections operate? Would the participation of medical workers, RNs, EMTs medicalize this effort in a way that would create barriers? Or could it be done in a way that continues to make access low barrier?
Yeah, I think the compassion club should be offered in tandem with overdose prevention services. And of course, that'd be subject to battles in the kind of municipal areas that it's offered as well. But if it's easy, or if it's possible, then it should be done. But if not, I still think a compassion club is still good to have. And there's other services like lifeguard or whatever that people can use, or peer witnessing. So if it were offered in tandem with overdose prevention site, it wouldn't be with nurses or doctors. It'd be a peer-run site. It'd be community-led. I don't think nurses have a place in overdose prevention sites. Maybe in supervised injection sites, they're I think mandated. But in overdose prevention sites, the ones that I've seen have worked best have been completely community-led.
Thank you. From Caden, is there a supposed plan for youth as we continue to see youth overdose and substance use disorder? I understand it's very hard to navigate and we don't want to be enabling youth. But we cannot be blind to the fact youth are using and not seeking services and dying. Thank you very much for what you're doing and for the presentation. Thank you.
I agree. There's a real need to respond to youth who use substances as well. I think it's going to be a very, very hard battle to fight, and I don't necessarily think that's something we can push for right now. I think we barely have public support as is, and to kind of pivot to giving kids drugs is we'd be chased out of town, I think. But I think it is something that needs some creative solutions, and once we begin working with more kind of government partners, I think it's something we can a model will be talked about like that as well. Because I think if there's places like youth overdose prevention sites, I think that's one of the first steps. Is once we get those, I think there's a real argument that can be made for including safe supply access at these sites as well.
Awesome. Many comments thanking you and sharing that it was an excellent presentation. Even someone from the US was tuning in.
Right.
Question from Petra with Mom Stop the Harm. The recent op-ed in the Globe by Lamb showed the extent of misinformation the public is fed about safe supply. How do we combat this?
I mean, yeah, I read that article by Lamb as well, and it was very disheartening. But just a comment on that. He said that the evidence was anecdotal, and then began to cite his own anecdotal evidence. So I didn't put too much weight behind it. And there's always going to be proponents. I mean, you look at anything, any sort of public health measure, like whether it be vaccinations or water fluorination, or whatever they're there's always going to be proponents and opponents. And I think it's just public information and public education is just, it's a campaign. It'll take a very long time. But I think for policy change to happen, direct action is the best tool to make it happen.
Yeah. Thank you. And from Robin, will there eventually be a safe option for users that have become addicted to down, which is fentanyl based?
I guess the question is, do we plan to offer fentanyl as well? And I think that is definitely something that we're going to look into again. Like when we were kind of pushing this, it was trying to find something that was palatable enough to actually happen. And I don't think, fentanyl was at that point. And it's kind of reiterated by the police responding to the complaint against them, where they explicitly said, we probably won't we didn't intervene because they weren't giving out lethal amounts of fentanyl. I think that's what they said. Or something along those lines. You're kind of reading between the lines saying, if you give out fentanyl, we're going to have to reevaluate our approach to this. So, as an organization, we absolutely do think that, fentanyl can be used safely as long as people know exactly how much is in it. If we do our pilot study and it seems like heroin isn't, cutting it for people, then we would, look into fentanyl options as well.
Great. And from Leslie McBain, I
know her.
Yeah. Jeremy, does DULF have an agreement with MySafe regarding the machines?
No, we don't. We've casually chatted about it, but until we get sanctioning, a lot of these kind of agreements and support are a little bit moot. But I have no doubt. I think Mark Tyndall and MySafe would be 100% on board. I mean, I don't want to speak on behalf of them, but they're a great group.
Great.
And I am now on the board of MySafe, so you have a supporter in there. So.
That's awesome. Many more comments saying thank you for fighting the fight with us, and an amazing presentation. I love DULF and what you are doing. So you've got lots of support behind you for this model that you're working on, and thank you for the presentation today. I don't see any further questions, just lots of positive responses.
I saw a question in there from Carrie about, I also know Carrie, about dark web education,
Okay.
and if we think it would be useful. And we've tried with some small groups, and I've tried with individuals to teach them about the darknet and how to use it. And it's a very tough thing to navigate. It's it's a dangerous place in terms of getting ripped off. I have been scammed on the dark web as well, and I take as many safety precautions as I can. So it's not just about teaching people how to access it, but also how to leverage some pretty kind of techie new methods to make sure that they aren't getting scammed. And there's very, very good scammers on the site, on the dark web. So I think dark web education would be good, and I think DULF may eventually put out some sort of guide, but also I don't think that's going to be a solution.
Great. And Heather Hobbs here in Victoria just commented, we're finding with our prescribed fentanyl program is that people's tolerances are incredibly high and that physicians are really underestimating doses. So in terms of reducing risk for people with high fentanyl tolerances, it's more about providing high enough doses versus being concerned that they're too high.
Yeah, I mean, when you look at the fentanyl equivalency charts for morphine, heroin, and these are kind of, general, these I think are estimates. Like heroin's 4 times stronger than morphine. So if you're going to prescribe someone heroin for morphine, morphine for heroin, you need to prescribe them 4 times as much. And fentanyl is 25 times stronger than heroin. So you're, have to, for someone who's taking a gram of fentanyl per day, you multiply, that's like 100 grams.
Yeah. Okay. Just another comment. I'm curious, has your team looked into approaches Europe is doing surrounding overdoses, and also why aren't all provinces collaborating together to tackle this nationwide issue?
That's a really good question. I also ask myself that, but there's definitely support coming from DULF from all across Canada, and people asking how they can do the same things. So hopefully we can have people from every province working together. I don't know why government doesn't work, but maybe somebody else can tell me. What was the other part of the question? Looking at models in Europe? You're gonna have to be more specific. I don't know. I think there's a lot of different people doing different things.
Yeah. Okay. Great. Any other questions or comments before I hand it back to Leslie McBain?
Great work, Jeremy. Well done.
Thank you.
Thank you so much. There's so many positive comments in the chat, Jeremy. So thank you so much. I'll hand it back to Leslie Neal.
Hi, everybody. Yeah, thanks, Jeremy. That was awesome. I learned a lot. I thought I knew everything, of course, but I didn't. And I mean, we have so many people on this webinar that now have the information, and it will just support will just go up from here. So yay for our side. Let's keep it going. And we, as you know, Mom Stop the Harm totally supports DULF. Is definitely, we're embedded in DULF, and we will do whatever we can to support. But I think you've already submitted your SUAP. Is that right or wrong? Your application for a SUAP exemption.
That's correct. We submitted both. You know, if there's organizations who want to send us letters of support, we'll still send them to the government to continue to demonstrate it. We also have a petition going around online that you can, I think, find through our Facebook or our Twitter. Both are DULF BC. Or if you go to dulf.ca, we have all the information there, and there's also ways to donate.
That was my next question. So yeah, financial donations to DULF are really important. We have to keep this going. Thank you so much, Jeremy, and we really value all your education and all your information on this. And we might do this again sometime. You know, we'll have people again who are more people who are interested in this as time goes by. So if there's no other business, I will say thank you and goodbye and good luck to everybody, and stick with us. Please join us, Mom Stop the Harm, if you have not, and we'd be glad to see you. So goodbye.
Thank you, everybody.
Thanks.